CMEs and CDPs. So, brief introduction. Dr. Parthopratim Dutta Majumder, he is a very well-known figure, a well-known name in ophthalmology, especially in uveitis. He is an international and a national speaker. He has written many books. He has chaptered more than 70 chapters of books and lots of research, publications. He is a senior consultant in Vanlalhruaia in uveitis and intraocular inflammation, and he has been a speaker in many of AIOS teaching, you know. So I think I can go on forever, but better give him more time. Yeah, we all know him already. Let him please, take the mic.
Introduction I received. First of all, thanks to Ophthalmological Society of Mizoram. I realize that it's not only awesome, it's really awesome. So I really enjoying for last one day the beautiful this city, and it is so beautiful this city. Morning I texted Dr. Diki that can you just give me a job, I'll stay back here. So it's a really great pleasure in this city back. I think after 46 years, because I left the city when I was 2 years old. So it's a nice actually moment for me. My mom and dad, they used to talk about this Aizol and all. My father was a professor in Pachunga College, so it's wonderful to back here. So I'll be talking about ABC of uveitis. So let be it can be interactive. Any point of time you have a question, no? You can just raise your hand and you can ask me questions. Let's not go for finishing the talk and then everything will be diluted. So you can anytime you can interrupt me, make it a very friendly discussion, and you can ask me any questions. So I'll be just going through the very basics of that. I think already it has been discussed, but still I want to say that nowadays we have only one classification of uveitis, that is called standardization of the uveitis nomenclature. Now, why we use this standardized nomenclature? The main reason is that so that if you are diagnosing a case of uveitis sitting in Aizol and the patient next day goes to Chennai, so that we can have a similar diagnosis. I can understand that what kind of inflammation he or she is having. Similarly, the same patient is going to France. If you are writing that anterior uveitis, he will understand, okay. So now let's see how it is. So the usually comes with redness and eye pain. They rarely have vision problem. So they only here the primary site of the inflammation is anterior chamber. Remember here the patient may have some cells in the vitreous, but that will be labeled as intermediate uveitis. If the primary site of the inflammation is anterior chamber, then it is anterior uveitis. The second one is that intermediate uveitis, where the primary site of the inflammation is vitreitis. So there will be a lot of vitreitis in this patient, and this patient usually presents with floaters and blurring of vision. Sadly, most of our patients actually come when there is a drop in the vision. That means when the CME will occur, that time the patient will come. So the third variety is that posterior uveitis, where retina and choroid is the primary site of inflammation. You will see some kind of yellowish lesion in the fundus. And you can, so this that the patient presents with the diminution of vision and metamorphopsia. The patient will have difficulty and various shape and size. No, a straight line, the patient can't see properly. So the fourth variety is almost like this, but there is inflammation everywhere. It's like inflammation there in anterior chamber, inflammation there in is vitreous, inflammation is in the retina or choroid. And one cannot make sure which one is the primary site of inflammation. So these are the patients, they can have redness, eye pain and diminution of vision and the severe category of inflammation. So broadly, these are the classifications we have. So when I show this slide, I always tell the people that the most important test of in uveitis is microscopy. So people think that I'm talking about this microscope. No, this is not the microscope. You look at this. This is the microscope we have. Have you wondered? This is the microscope where we can see our eye. with 20 to 40x magnification, we can see the inflammatory cells, the macrophage we read in our textbook, but in slit lamp we can see the macrophage floating in the anterior chamber. We can see a lymphocyte actually deposited in the what we call keratic precipitates. So these are the cells we can see. So this is our microscope, and we have such a beautiful instrument in our hand. So just think about a rheumatologist. You have sent a patient of giant cell arteritis to a rheumatologist. What a rheumatologist will do? He can't diagnose anything. He will refer this patient to a surgeon. The surgeon will do a biopsy. This biopsy will go to a pathologist. The pathologist will see under microscope and will say, okay, there is inflammation. And then the rheumatologist will start treating a case of giant cell arteritis. But whereas we have this instrument where we can see the anterior chamber cells, what cells are there I can see. We can actually quantify also. The 3+ cells means severe, 1+ cells means little less. So this instrument we need to actually use properly in our clinic. Now, what are the problem in using this instrument? Sometimes you examine a patient, sit the patient for examining a patient, and the patient is so photophobic that you are afraid to actually magnify or put the intensity in full. So you are afraid of that and you reduce the intensity of the beam and you can't see properly. So I'll show you what happens here. Now, for example, if the patient is photophobic, so that what we do, we rheostat our brightness, we reduce. But with that, you actually can miss your 1+ cell. 3+ cells you won't miss. But if the patient is having occasional cells, if the patient is having 1+ cells, and you have reduced the intensity of the light, thinking that the patient is photophobic, can't look properly, how will I examine, then you are going to miss this. So what you should do this. Make a slit, very thin slit, but remember the intensity of the light should be full. If you are reducing the intensity of the light to lowest, to avoid the photo, you will miss many findings. So this should be the way of actually examining a patient who is photophobic in your clinic. Now, next mistake we do, we sometimes see the pigments and confuse them as cells. So there are certain actually differentiation point here. So the cells are relatively large, they are yellowish white, and if you see a beam of light, you see this yellow color beam, you will see that this sparsely actually placed in a beam of light. Whereas you see the pigments, they will be densely packed. Like you call it if you see in vitreous, tobacco dust sign. So it looks like actually tobacco dust, brown and red in color and densely packed. So these are the basically iris pigments, there's erythrocytes in case of high fever, or dead macrophages filled with melanin pigments. So these are not actually signs of inflammation. Active signs of inflammation means inflammatory cells which comprises of leukocyte, and these are large, sometimes you will see large cells like the swollen macrophages who has engraphed one leukocyte and become actually swollen. So these are the cells you see under slit lamp. Now we actually don't examine the patient before dilatation. So sometimes what happens if you want to see the fundus, you just ask the patient to get after refraction, you just ask the patient to get dilated, and this especially happens those who are doing vitreoretinal practices. So they see the posterior segment fundus and don't see the pupil before that. Now look here, many findings you can miss. Like for example, this you can actually miss. This if there are the peripheral iris atrophy, if the pupil is dilated, then you can miss. So this is, I'll come later that why it is. This is a case of Fuchs uveitis. You will miss Fuchs uveitis if you are dilating and examining the patient. Now look at this patient. This patient looks absolutely normal. The patient has cataract and all. Now if you see the patient before dilatation, you see. So copious nodule you will miss if you are examining the patient after dilatation, because the nodules will stretch with the stretching of the pupil, the nodules will go. Now, another problem we do is the examining the eye in diffuse light, and we don't examine this eye in all quadrants of the, because slit lamp, when the patient is keeping the chin, no, patient will be looking straight towards you. Sometimes it's very difficult to see all parts of the eye, but you have to remember, you have to see the entire quadrant of the eyeball. Now let's see here. In this patient, you see the patient has come with redness, pain, and irritation, and you can see a lot of dilated vessels, congested vessels are there. Here, the patient again, another patient has come with, you can see in slit lamp, you can see that there is a dilated vessels here, right? So I'll come back to this two picture later. Now you see these two patients. So this patient, if you see the other quadrant, you can see here there is this necrosclera. So it's a necrotizing scleritis. It is not as simple as this kind of scleritis, because here the sclera has started melting. So you need to treat it as a medical emergency rather than treating as a simple case of scleritis. Here you see, which may look like a episcleritis and patient may not complain of pain. Here you see it's a big nodule. So this kind of nodular episcleritis can be seen in ocular tuberculosis. So it's an important point here is that you need to examine all the quadrants of the eyeball so that you can clinch the diagnosis. Now coming to that, sometimes you need to examine this palpable conjunctiva also, because palpable conjunctiva, this is a case of brimonidine-induced anterior uveitis. So the patients who are glaucoma patient and you have started the patient on brimonidine, they can come back with anterior uveitis and this kind of congested palpable sclera. So you need to just change the medicine into another anti-glaucoma medication you have to change, and the patient will be all right. No need to give any other treatment. This is actually you can see that millet-shaped nodules in the conjunctiva. So if you can actually invert the lid and examine and find this, these are the signs of the sarcoidosis. Ocular sarcoidosis can have this kind of nodule. Now, this is a case of anterior. So, most common uveitis in our clinical setting is anterior uveitis, right? So now I will see that how a case of anterior uveitis we can decode. So you see here a 26-year-old male presented with recurrent attacks of redness, ocular pain, blurring of vision in the left eye. Now, how we should proceed? Now, the main actually guideline will be this, that history and slit lamp examination, we need to find out whether the eye is granulomatous uveitis or the non-granulomatous. Then we'll see what is the course of the uveitis. Make sure that it is only anterior uveitis, posterior segment is not involved. What is the laterality of the uveitis and the specific clinical sign. Now, can you tell me what is the course of the uveitis here? I have written on it. So it's a recurrent, right? And what is the laterality of the uveitis? It is unilateral. So let's see here. So we have the course. We have seen that it's a patient is already giving a history of recurrent uveitis, and the left it's a unilateral. So this is the common practice in our clinic. We see the uveitis patients. Now, what are the causes of that? So the unilateral anterior uveitis, remember only three common causes. One is HLA B27 associated uveitis, another is Fuchs uveitis, another is viral uveitis. Now we need to see how we can decode these three entities, because these are the most common anterior uveitis you will see in your clinical practice. Now if you see here, the HLA B27 associated uveitis, it is unilateral but it is alternating bilateral. Means the patient will come and will tell you that I had the same kind of redness and irritation in my right eye, and after 3 months it has again come to left eye. It is saying like that. And it is actually, if you see, it is acute or hyperacute. Now, what is acute and hyperacute? Like some uveitis patients, I don't know, you face this kind of, I get a lot of patients from, so some patients will come to me and will tell that I went to a dhaba and had some lassi or drink. After that, my eye became red. One lady will come and tell that I went to a marriage function. Everyone was praising about my eyes, that my eyes are so beautiful, and next day my redness started coming. This is not the compliment or the history. You need to understand that the patient is telling you a pinpoint. She or he can pinpoint when the pain started. That means it is acute. Now, a chronic patient will give history like that, Patient will ask from when your eye problem is there. She will tell, yeah, it's there from I think last year December. The accompanying attendant, husband or wife will tell, no, no, not December. You went to doctor June, no? Oh, baby, it's June. So that means the patient can't pinpoint the onset of a disease. So that is not acute. Acute is that disease which is so sharp and sudden onset that patient can remember that Tuesday 12:30 p.m. I had this. So this is the nature of a acute. So this is actually case of a acute. HLA-B27 will have a acute, and this will have a pain, redness, and actually have a photophobia. And what are the findings you will see? You will in anterior chamber, you will see it is very high fibrinous content. Thick kind of material is there in anterior chamber, not like only cells and flare floating there. So this is very important to understand that. Another problem in this HLA-B27 patients they will have the back pain. Okay, so these patients with back pain, they will have lot of inflammation and they will come like this kind of picture. So remember this next time you see a patient like this in your chamber. Now the second entity is your viral anterior uveitis. Now viral anterior uveitis is unlike HLA-B27, it is almost always unilateral. If it is, mark my word, if it is happening in both eyes, then you should be at least, means there are some exceptions in medicine, but remember if it is happening both eyes, think that it is not viral. Because viral uveitis almost always from the beginning it will be confined to only left eye. If it is in right eye, it will be right eye. So there is no confusion about that. So second thing is they have variety of symptoms, like if you start the steroid, patient will be fine. If you have stopped the steroid, after 3 or 4 days, again the patient will come back with that. So these are the typical this thing. Sometimes if you are lucky, you can see the corneal signs like this, corneal opacities or this kind of Descemet's fold you can see. And it's important to see all these signs. And also these are the viruses. You see normally these are the trabecular meshwork. So from this pores, no, the aqueous will outflow. So here what happens, these viruses will call trabeculitis. So they are actually trabecular meshwork, you see that it has become swollen. So this will resist the aqueous outflow. So they will have a high IOP, sometimes 50 to 60 this can have. So remember only one thing, uveitis with high IOP can be seen in sarcoidosis, in children in juvenile idiopathic arthritis, syphilis, and this kind of toxoplasma and fuchs also can have this. You want to take photo? So if you have any query or anything, you can just ask me. Huh? So CMV anterior uveitis in the sense, I don't know about in India we don't do, see by my friends from the Singapore and all, they keep telling that they see a lot of this thing. So this is a photograph from Professor Chi in Singapore. So she has defined that if you see this kind of coin-shaped opacity, no, and with this kind of pigmented capes, then these are the signs of cytomegalovirus anterior uveitis. Now why I am telling this, because you may not have the PCR availability here. So you can see this kind of clinical signs where you see the round opacity and a lot of pigmented keratic precipitates, then you should not treat with acyclovir. It's the time to treat the patients with valganciclovir. So another important feature of the viral is this virus is no herpetic viruses. They actually causes lot of endarteritis. So they will destroy these iris tissues. You see that arteritis has caused the necrosis of that iris tissue. Here, this you can see. So these are the typical, if you see this kind of picture with anterior uveitis, make sure, we are 100% sure that it is a case of viral anterior uveitis. How common is leprosy in Mizoram, but in Hansen disease also can come like picture like this. And anterior segment ischemia and previous attacks of angle-closer glaucoma also can have picture like this. So again, these pictures are, you see here, these are the pigmented keratic precipitates. You see these keratic precipitates means what? If the anterior chamber cells are there and you see this kind of pigments, these are not signs of old capes. These are the active capes. Means a macrophage floating in the anterior chamber has engulfed a pigment cells, large pigment, and it has turned into a brown color. So that's why it is brown or pigmented. Another pointer where you can suspect the viral anterior uveitis, if you see this kind of, no, this is little round oval shaped pupil and the patient is not using any cycloplegic, any drop, then it is a sign of anterior uveitis due to viruses. Because viruses will cause destruction of this sphincters. So that's why pupil will be D-shaped. So that's why we call, if you see this abnormal pupil and the patient is not any cycloplegic, then it's a sign of viral uveitis. Now coming to the fugue uveitis, before going to that, I just want to say, because in medicine we have read about that. So recently this November issue of Indian Journal of Ophthalmology, we have published our data of 339 patients from India. Now this fugue uveitis, you see our study, I won't give you any complicated or any figure, I'll just try to simplify my paper here. So what we have realized, this fugue uveitis is most underdiagnosed and overtreated conditions of uveitis. Now this thought came to my mind when I started reviewing my old files. When I started my career in 2009, so I started going through those files that what all is happening with these patients. And I realized that many of the patients actually I thought as an intermediate uveitis actually was a case of fugue uveitis. Then I checked the other people's file, other diagnoses and realized that that is what happening. And then I did a study and it showed that it is one of the underdiagnosed, overtreated, because we treat it with oral steroid, unnecessary, sometimes we give immunosuppressives, but it's basically only treatment with a case, only treatable with a topical steroid. And my study showed that if it is patient is having fugue uveitis and cataract, no need to wait for 3 months. Directly you can do the cataract surgery. It is one of the safest uveitic cataract which you can operate. No need to give the steroid and unnecessarily complicate the course. So what all we saw, that 1/4 of these patients were misdiagnosed with intermediate uveitis, and also another case of anterior uveitis, like people thought it's HLA-B27 and started the patient on steroid. And these patients can be rarely bilateral, and heterochromia is extremely rare in India. It is only 6%. Now, if you remember what you have read in your ophthalmology book, Kansky, it is heterochromic fugues, heterochromic iridocyclitis. That is true when you have a very light color iris, like a Western population they have a very light color iris. So heterochromia you can see. Those who are having a dark iris, no, like in Indians, black eyes we call, so there you can't see the heterochromia. So heterochromia is extremely rare in Indian population. It's only, we found only 6%. So iris nodules and iris atrophy also can be seen, and the most important is this vitreous membrane. If you see this membrane, you think that it is a case of intermediate uveitis and treat with steroid and treat it with actually steroid, but whether it's a case of fugue uveitis. Dr. Diki, let me know if I am standing between dinner and the talk. No, I'll just have one talk and we'll finish it off, because I have compiled everything in one talk. But let me know. I don't have any other thing, because it's no. I'm just asking about anyone you feels. No, we can take a break also after dinner. Also, we can take. I don't have any problem. Okay, I'm here. So you let me know your convenience and all. So this is about that fugue uveitis. So now fugue uveitis is typically unilateral. It runs a chronic course, and that picture I was showing, no, if you see this kind of, see, this is the polarity of the iris, which divides the iris into ciliary zone and the pupillary zone. So this here you see, it has become a velvet kind of appearance. That is called the, normally if you, what you see big pits here, no? But if you see that blunting of this and this kind of picture, then it indicates that you are dealing with a fugue uveitis. It is in undilated condition. Second point, which is very important, is that in spite of this inflammation for last 5 years or 6 years, they won't have any synechia. The pupil will be absolutely mobile and round. So these are the cases actually, and you see stellate KPs and all. So these are the cases, no need to give steroid, oral steroid for 1 month, 2 months, and then do cataract surgery. You can just give a topical steroid at least 5 days or 7 days and do the cataract surgery. The prognosis is absolutely fine. So what in my hospital, what I have done, I have taken patients of 190 of my other department colleague who has given the steroid, and my patient where I have done 50 patients of huge uveitis where I have not given cataract steroid and I have done the surgery. So there is no difference in the outcome. So these are the patients are the safest patient if you are want to operate. Now this kind of debris you see.
Sir, one moment, sir.
Yeah.
What about?
That's a Emsler sign is a very important sign. Sometimes if you do gonioscopy also, if you press the eyeball little hard, no, that time also you can see this bleeding because the capillaries which are there in the angle of anterior chamber, no, these are very fragile in fused uveitis. So that's why they bleed. So when you enter the anterior chamber, do a side port entry, you can see, which is confirming your diagnosis that it's a fused uveitis. So this kind of actually opacity you can see in this thing fused, and these are the opacity even if you give steroid you don't do. So that's why people sometimes mistake it as a intermediate uveitis. Now coming to that, all these terms you have heard, no? Choroiditis, chorioretinitis, all these are umbrella terms, means you can't actually treat. For example, retinitis, there can be several causes of retinitis. Each cause will have a retinitis and you have to treat that cause. So there is nothing that you can treat a case of retinitis. You have to first go to the cause, what kind of retinitis it is. Then only you can treat. So Wood's classification, already I think she has discussed, so I won't going into that. So coming to that, this is very important, that redness and pain. So this is interesting that remember these 3 points if you want to diagnose a case of scleritis. So the number 1, the presence of pain. Now this pain is actually severe excruciating pain. This pain will worsen at the eye movement and you ask the patient that what time of the day your pain is severe. Patient will tell at night. So don't give this clue, just ask the patient that what time of the day your pain is. And second thing is, remember our Indian patients, they can't actually differentiate between discomfort and pain. All patients will tell that I have eye pain. What kind of pain? You check them that whether the pain is so severe that you need to take any analgesic before, then that is the pain of scleritis. So excruciating pain, we only read the literature or book and we forget that it's practical implement. We ask the patient, do you have pain? And all patient will note their head, yes, I have pain. So this is not the pain. So you need to differentiate that. And this pain sometimes can radiate to various part of the also. But most important is that it worsens at night. The second thing is that severe tenderness. If scleritis patient won't allow you to examine. You have to put a lignocaine, paracaine drop and then only you can actually examine. It's so painful. So remember that. The most important is that persistent of vascular congestion with topical vasoconstrictor. If you are using a T+, no, which contains the phenylephrine, which is a vasoconstrictor, you can actually that. So remember these red flag signs in ophthalmology, if you see them, like if you see this kind of corneal involvement, if you see this kind of necrosis patches, this kind of, so these are indicator of some systemic lethal vasculitis like Wegener granulomatosis, or you are dealing with a rheumatoid arthritis. So these are the patients require life-saving pulse steroid or pulse cyclophosphamide kind of drug. Now coming to the most important part of my slide, where I always stress this fact, that a 43-year-old lady diagnosed as a iridocyclitis, treated with topical steroid and cycloplegic, and the Monto test was negative, HRCT test normal, HLA-B27 negative, RANA everything was negative. And this lady, the treating doctor examined the lady with a direct ophthalmoscope. And the direct ophthalmoscope picture, or even if you use 90D, no, it will give you this much view. Correct. So this posterior pole fundus examination showed hyperemic disc, everything looks normal. So the patient was continued and dropped. But this patient, when I dilated in my clinic, you can see. So the same patient, if you are not doing a direct indirect ophthalmoscopy or look at the peripheral fundus, no, you can miss something dreaded organism called acute retinal necrosis. Now, as I told that all the patients going to tertiary center, they will be biased. But I don't know, whatever patients I get from Mizoram, no, I have seen that the herpetic viral diseases are very common from Mizoram. Maybe the patients who has gone to my clinic mostly, but I have seen a lot of these things. And 2-3, I think Dr. Dickey also knows that. So acute retinal necrosis is a this thing. So all of you be aware of this dreaded disease, especially any kind of viral disease. Now sometimes, no, when we talk about all these things, sometimes this white eye uveitis we talk, where there is no congestion, but the patient is having uveitis. So remember pars planitis, Fuchs uveitis. In children, they're notorious because the children often they are blind, then only we diagnose it. Because before that they don't complain, they can't tell that we have a diminution of vision. So I think whenever you are going for school health checkup, no, make it mandatory to spread the message that all children should undergo a mandatory eye examination from OSoM. You can actually carry initiative of this because we don't know how dangerous it is. Only the patients are blind. That time we are diagnosing that it's a juvenile idiopathic arthritis. Another reason for that is that it is white eye. The eye looks completely white, and the children looks absolutely normal until and unless he or she becomes blind. Now coming to here, you see you have dilated the patient and you are seeing something red, yellowish white kind of lesion. Now you have to actually see whether it is a retinitis or choroiditis. Now first see, if you look at this, no, the retinitis will start as a white cloudy patch, whereas the choroiditis will have a slightly yellowish color. Now if you see here, the retinitis, you can't indistinct, it will have a very indistinct outline. It's like a cotton wool, no, or a cotton bud, cotton there. So you can't have a proper outline. Whereas that if you see, look at a case of choroiditis, you can fairly make a border kind of this. So this is a differentiating point, and the most important point is here. In retinitis, if you are not sure whether you are dealing with retinitis or choroiditis, just follow the blood vessels. Now this blood vessel, if you see, the retinitis occur here and the blood vessel is here. So you can't see the blood vessel. And in choroiditis, you see the choroid is here. So the choroiditis is occurring here and the blood vessel is above that. So you can see the blood vessel clearly. So remember, if you are seeing some yellowish white kind of lesion in the fundus and you are not sure whether it's a retinitis or choroiditis, just follow the blood vessel, it will give you the answer. Now remember one thing, there are only two exceptions other than always think of ruling out the infective retinology. So the number one exception is the Behçet disease, where you can see the retinal infiltrates. How common is Behçet's here? Any idea? Means you people see? Only one, no, that child, yeah. I think it's a Behçet is a silk root disease. So we see mostly from the Kashmir, Punjab, that area, close to that silk root area. Very common, uncommon in rest of the country. Another important point is that intraocular lymphoma. Now this lymphoma, sometimes that young and old gentlemen may come up like this kind of picture, that RP level infiltrate, no? So these are not retinitis. These are the cases of intraocular lymphoma. Now if you see this kind of retinitis patch, only one, now a single solitary patch, then always rule out the protozoal causes. Toxoplasma can be a most common cause. How common is toxoplasma here? See, because if it is the people consuming little undercooked meat, pork and all, then it can be so. So sometimes you need to understand that sometimes you can see this kind of picture. So this picture is not very clear because of the resolution wise. So if you see this multiple exudate like this, with lot of vitreitis, then you have to rule out pars planitis. If you see confluent areas, then it is a viral infection. If you see single solitary lesion, then it is toxoplasma. And if you see kind of tractional band, then it is toxocariasis. Now remember one thing, if you are seeing a recurrent vitreitis in elderly patients, always think of ruling out lymphoma. Now particularly a elderly gentleman who never had uveitis in life, after 68th birthday or after 65 years, elderly person is having recurrent attack of vitreitis, then you need to rule out the intraocular lymphoma. So coming to that choroiditis, you know that TB will have this kind of picture. If you see this kind of small patches around the vessel, no, then it is a choroidal tubercle. I am giving another example. If you see this kind of patches, then it is due to tuberculosis. Now there are two entities called serpiginous-like choroiditis and classic serpiginous choroiditis. So one happens because of the tuberculosis, the other one due to autoimmune etiology. But without doing test also, you can actually make out whether it's due to TB or it's due to autoimmune. So the number one is serpiginous-like choroiditis occurs in very young patients, whereas that serpiginous-like occurs in elderly patients. The number two clue is serpiginous-like choroiditis, that is TB-related choroiditis, or is usually unilateral. Don't be under the impression that it is TB, so it will be bilateral. No. The serpiginous-like or TS happens only in one eye. If it is a classic serpiginous-like choroiditis, then it occurs in both eyes. The another point of differentiating is serpiginous-like choroiditis is a multifocal. It starts like this. See? Whereas that classic serpiginous choroiditis will have a geographical map-like pattern. So you need to differentiate between these two entities, and if you see that serpiginous-like choroiditis that associated with TB, no, they usually spare the juxtapapillary area. Here the area will be spared. You see there is no lesion. Whereas serpiginous autoimmune variety will involve this juxtapapillary area. The second point, third point is they are associated with some inflammation in the vitreous. The TB will have some inflammation in the vitreous, whereas the autoimmune, no, there won't be any reaction in the vitreous. So you can differentiate based on this picture. Only one glitch is here. If you are delaying your diagnosis, no, you are delaying it after without treating, then you can see this multifocal like serpiginous-like choroiditis, and sometimes they can actually coalesce and can become like autoimmune variety also. Now just coming other few, this you can see this choroidal nodule tubercle granuloma. This can be actually large. This can be seen in TB if you are not treating it properly. So that means all bacilli is multiplying inside that. So exudative detachment you see here, it's a choroidal large with the exudative retinal detachment. So you can actually differentiate between TB and sarcoid. The sarcoid granulomas are multiple in number and occurs in both eyes. Tubercle granuloma occurs only in one eye. And these are much larger, solitary, and sarcoid you see multiple granulomas are there. So that's how you can actually differentiate. So this is an example of subretinal abscess. So this subretinal abscess should be treated you see another, these are all due to TB. So I'll show you a case. This is a lady, a 20-year-old female who presented with diminution of vision, and you know why? Because of the patient was external hordeolum, and for that she was treated with oral steroid, and the patient actually came up with a diminution of vision in 2/60, and you see here this is the clinical picture. So this was the huge subretinal abscess here. We did an ultrasound B scan. You can see the extent. And we did the test. Montu test was positive, and the quantiferon TB gold test was positive. And we did a HRCT chest, and that was within normal limit, and everything was normal. Now with this picture, we could have we thought that whether it's a TB or it can be some other bacteria also. And PCR showed some other bacteria. But then we realized that is the contaminant of the sample, so it's not this thing. So we thought it's a kind of TB only. So we started treating the patient with oral steroid 1 mg per kg and plus ATT we have given. But if you see the picture, this requires something. Oral steroid is not going to control this. because it will take long time, and the already her vision is 2/60, so she may lose the vision. So we decided to give intravitreal moxifloxacin and treat the patient. Now intravitreal moxifloxacin is very easy. You take it as moxifloxacin vial, fresh eye drop, just draw the 0.1 ml and just give an intravitreal injection. No need to dilution at all. It's as simple as that. So the intravitreal moxifloxacin, see, we have given intravitreal injection and you see the response here. So it's a very good drug actually to treat this kind of TB. You see, this was the first, after 1 week of injection, this is the picture. This is the picture with the visual acuity gradually improving to 660. This time we realized that fluid is not observing, so we give an injection of ranibizumab also with intravitreal moxi. And you see here, its gradually vision is 6/36. That time we have given 4th injection of intravitreal moxifloxacin and ranibizumab second dose. And the patients see the mass from here to here, it has become 6/24. So this was the presentation, and after the last follow-up, this is the presentation. Macula is absolutely normal, 6/12 is vision. So sometimes this kind of intravitreal injection actually helps you in treating this kind of patients. So this is a slide I'll skip here. So this is exudative retinal detachment. Now see, exudative retinal detachment can happen like this. Like you can see that subretinal fluid, some pockets of fluid in the posterior pole, or it can happen like this also. It can be bullous retinal detachment also. So I'll come to the treatment and all. There are a lot of causes. One thing you must remember, you must do a fundus fluorescent angiography in case of this, if you see this kind of picture. Because if you are seeing the pockets of fluid in posterior pole and you are trying to treat with steroid, may be God forbid that it's not a case of CSR. It will worsen. So always do a case fundus fluorescent angiography and then only try to treat that. So they will have this kind of optic nerve edema sometimes and the pocket of fluid, and the most common diagnoses are actually inflammatory leakage, posterior scleritis and sympathetic ophthalmia. If the patient is having any history of any surgery or any penetrating injury, then they can be labeled as a sympathetic ophthalmia. So this is about exudative and if you have a combination of that. I will skip this slide. Yeah, just a few retinal about vasculitis. So when I have come here and become a friend with all, so remember, if you have any case, anything, you can just email me, and I am usually available in WhatsApp if there is an interesting case you feel, because many of our patients, I feel, they can't travel from Mizoram. It's very difficult. It depends on the financial and all so many other burdens. So sometimes actually we can actually help people with a small communication, no? So can actually help. So feel free to do that if you have some query about that. Now coming to the retinal vasculitis, if you see that there are, if the veins, which vessel is involved first, that is important. If you see the veins are involved, then arteries mainly involvement can be seen in syphilis and in viral cases. So remember, only two of each. If both are there, then multiple sclerosis and Behçet disease. Remember, multiple sclerosis we don't rule out. Because the patient comes to you, we don't investigate, we don't do a CT scan brain or look for it, and after that patient stops coming because now the patient is having bigger problem. The CNS involved means he will least bothered about the vision. First he needs to. So these are the patients. That's why we people don't see cases of multiple sclerosis with until and unless we are working in a multi-speciality hospital. No, we don't see cases of ocular involvement in multiple sclerosis. Because if they go to neurologists, they are not in a position to come back to you. So these things, this will skip. You have a lot of important point to touch. Oh, one more thing is that if you do a fundus fluorescent angiography and you see this fund-like leakage, then it's indicative of the Behçet disease. This already we have seen. Only one advice I want to give: if you see actually any NV, due to uveitis, you have to remember that you need to treat with anti-inflammatory treatment, oral steroid. Not only anti-VEGF injection will occur, because the mechanism of NPE formation in uveitis is different. It's because of the inflammation, not only because of the anti-VEGF. VEGF. Yeah. So coming to that optic disc involvement, quick pointer for that. So it's a optic disc involvement can occur due to panuveitis, like a case of VKH, and sometimes you can see that one lesion near to the optic disc. So this indicates it can be due to toxoplasma, tuberculosis, toxocara, 3T. 3T, if you see this kind of lesions near the optic disc, tuberculosis, toxocara, and toxoplasmosis. Now, if you see optic nerve granuloma, remember two cause, TB and sarcoid. This is a very interesting, this neuroretinitis. All of us, we know this kind of picture. But remember, forget about the etiology. Neuroretinitis is always unilateral. If you are seeing a patient like neuroretinitis like picture and it is bilateral, then what will be your diagnosis? It's not uveitis. Rule out systemic metabolism disease. Rule out whether the patient is having diabetes, have uncontrolled hypertension, or the patient is having any raised intracranial tension. So these are the three top causes if the patient having neuroretinitis picture and if it is bilateral. So just last few this thing about, if you see this saddle-shaped nose, then it can be due to leprosy, it can be due to vaginas. This is swan neck deformity. It can be seen in rheumatoid arthritis. If it is there, you can actually pick up. Cauliflower, this kind of boggy rear can be seen in relapsing polychondritis. So these are the signs actually patient will tell you. This is a butterfly rashes can be seen in systemic lupus erythematosus. Any kind of this necrotic digits indicates that patient is having severe vasculitis, like rheumatoid arthritis, some vasculitis which is causing damage. This Hutchinson sign that indicates that it's a patient is having viral disease, and this kind of vitiligo can occur in patients with Vogt-Koelnage-Harada disease or VKH. Now coming to that investigation, we need to always investigate the patients, but as the previous speaker has said the tone, if the patient is having granulomatous, always do investigate MON2, HRCT chest. I'll come to one by one, and this will be a very interesting part. So if you have a granulomatous uveitis, always do MON2. Now MON2 has two roles. If it is a positive, it can indicate latent tuberculosis. If it is negative, then it indicates sarcoidosis. So it adds in both the diagnosis. But remember one thing, based on MON2, don't treat a patient. If the MON2 is high, doesn't mean the patient is having tuberculosis. You have to look at the ophthalmic signs, whether the patient is having that signs of ocular TB, then only you can treat. Then angioconverting agent is available in ISO. Serum AC? No. Yeah. Send it. Yeah, serum AC actually can be this thing. So chest imaging, one thing which I have changed my practice, I have changed in my practice in last 6 years. If the patient is poor, I just don't do any imaging. Otherwise, only one test I do is HRCT. See, as an ophthalmologist, no point in doing a chest X-ray and telling that the chest is normal. Because the lymph node we need to, this sarcoidosis and other thing, we need to actually look for the lymph node involvement. So that is not fall in chest X-ray. So I have stopped doing chest X-ray. There is no point if you are, for eye reason, no need of doing chest X-ray. Always do HRCT, otherwise don't do. Because if you do chest X-ray, it will come normal, and based on that you will think that okay, chest is normal. So better not to do unnecessary test and waste patient's money. So liver function test is important. Sometimes it can be raised in sarcoidosis, or if the patient is having patient needs immunosuppressive, then you may need to give that. Now coming to that systemic rheumatic disease, we all do this thing. Remember 3 golden tips, only 3. The number 1, always correlate with clinical conditions before ordering the investigation. For example, if the patient is having just mild redness and you are doing ANCA or P-ANCA, C-ANCA, no point in doing that. So don't order hi-fi investigation which you don't know. There is a saying that if you don't know how to, don't catch a fish if you don't know how to cook. So if you don't know how to interpret it, what is the need of doing it? You will be in trouble. No, you have done all the tests and 1 or 2 has come positive. Anti-SM antibody. Many labs are doing it. But if it has comes positive, what you will do? So better not to do any investigation which you don't know. So that already I have been told. So no single test is diagnostic. You can't tell that patient is having ANS, patient is having SLE. ALA can be seen in anti-nuclear antibody can be seen positive in 40% of our population. So that doesn't need this thing. So there is no ideal biomarker, and negative test does not rule out any disease. That you need to understand. From this patient at 25 years of age, have a HLA-B27 like uveitis. We investigated HLA-B27 negative. Then after 3 years, again same symptoms. Again we suspected, again it was negative. And when it became 30 years, same symptoms, uveitis, that time it came positive. So it can be positive after a certain period of time. So serological tests in infectious uveitis has no role. Don't do a torch titer and based on treat. Because you have to remember herpes virus is a very ubiquitous virus. It is present in everyone's body. One autopsy study showed that the 95% of the human had herpes virus inside the body. So only based on that, don't try to treat it. So torch titer has no value. Two exceptions, only serology you should do in all patients. One is HIV and one is syphilis. So this is just I want to highlight that there is no point of doing a test and treating because toxo is always a clinical diagnosis. If you see this kind of picture, headlight in fog, no need to do any investigation. You can directly start the antibiotic treatment. So sometimes some diseases are always actually clinical, no need to do any test. For example, ARN, CMV retinitis, toxo, and non-infectious like Behçet disease, Fuchs uveitis, VKH. These are the tests, only the clinical picture you see and diagnose. There is no point to diagnose anything. But sometimes in these cases, no, it was highly actually because antitoxoplasma titer was negative. So in this patient we did PCR and PCR actually showed the diagnosis. So remember one thing, PCR is a test where you can test any sample from the eye. You can take even tear also and actually test for whether any organism is there or not. So it's a useful test, but because it is not available, no point in talking and discussing about this. So just keep this slide. I'll come to some slides which are 3 points to remember before treating a case. You should remember. The number one is it has many phases of inflammation like tuberculosis and syphilis. It does not come with a single that oh, if you see this, then this is TB. If you see this, this is syphilis. So it can have a various phase of involvement that you have to remember. Don't be blind that oh, this is not like this, so it is not TB. This is not like this is not syphilis. So don't be that kind of this. Second is it keeps on changing inflammation. So sometimes it can present like sarcoidosis. It can present with granulomatous uveitis also. It can present with non-granulomatous uveitis also. Similarly, the mutton fat capies, it's not only in TB. It can present in cases with viral uveitis also. The third is that masquerade and malignancies. Many of the patients disappear from our clinic and they don't come back. So this happens when we are dealing with masquerade malignancies. For example, the children where the diffuse infiltrating retinoblastoma can have seeding in the anterior chamber and it can mimic like anterior chamber inflammation. So in children and in elderly people, no, always suspect and rule out the masquerade. Now coming to the treatment of uveitis, I think I'll just conclude with treatment. So this is about ABCD. If you see that, first you see the anatomical site of inflammation, like where it is the site of inflammation. If it is the anterior chamber, treat with topical steroid. Similarly, if it is posterior segment involvement, don't treat with topical steroid. You have to treat with oral steroid only. So second important point is that the balancing the risk versus benefit ratio. So two important things, you have to think about the side effect. If you are giving oral steroid to a patient who is a porter by profession, who is carrying heavy every day. So don't do that. The patient can develop avascular fracture, femur fracture more than the other population. If the patient is having diabetic, don't give oral steroid. So you need to risk this balancing risk and benefit ratio. And the second most important point I tell that don't judge a patient from attire. Because if or from socio-economic condition, you don't know how important the patient's eye is. So always give him all the options and let the patient choose the treatment. Don't think that you think that, oh, he is poor, he won't be able to take ranibizumab while giving this injection. So you tell him all options, let him decide about the treatment. You don't know, he may be a cab driver or he may be a this thing, but you don't know how important. He's the only bread earner for his family. So the eye is the most important for him. So don't be in this bias. And skip this. So this is sometimes we happen. No, we just start the oral steroid and coming down to 5 mg, and again the recurrence has come. So same happens. Then what we do? We again go back to 40 mg and again start tapering, and again actually come to 10 mg, and then again there will be a recurrence. So that is the indication of your immunosuppressives. So immunosuppressives are required when there is a chronic inflammation and it is more than, patient is not tolerating 10 mg. Beyond even in 10 mg also patient is having recurrence of inflammation, means the patient needs now immunosuppressive, because more than 10 mg you can't continue for more than 3 months. That is not actually will be tolerated and patient may have some side effect. So always go for immunosuppressive if you reach this level of 10 mg. This is about the degree of inflammation. So sometimes it happens, no, you see this kind of picture. I think you were asking about optic nerve involvement, like this kind of. So the degree of inflammation is if the patient is having optic nerve involvement, if the patient is having macular involvement. Now how to treat? So you have to remember, if you see this, no, we have so many drugs we tell. You go to conferences and you see that people are talking about these drugs. Now you see that how long it takes. It takes 10 days to start acting. Mycophenolate takes at least a month. Methotrexate takes at least 3 months to start acting. So these are the drug only you read about in textbook, immunosuppressive, so many things. These are not for acute conditions. So for acute conditions, we need this intravenous methylprednisolone. If the patient does not have money, then you can give intravenous dexamethasone also. So these are the drug actually. Methylprednisolone reaches the attached retina within 6 hours, and in case of retinal detachment, it reaches within 2 hours. So these are the drug for acute emergency. Now these are the few tips I just want to give. One thing is that don't use incorrectly the eye drop. Don't overestimate the eye drop. You see a lesion here and you think that you will treat with the eye drop. No. If you see a case of posterior uveitis, pan uveitis or intermediate uveitis, don't treat with eye drop. Eye drop is not going to cure these patients. So don't try that. The second thing is that I think you pointed out very nicely. So this is what she pointed out, that cyclopentolate. It's like chemoattractant. It's like chasing a bull, no? Unnecessary irritating. So cyclopentolate will always attract the inflammatory cells, even in normal people. So in uveitis, if you are giving cyclopentolate, it will cause more inflammation coming towards there. So better to use homide instead. And another important thing I always tell, you look at this patient, uveitis is treated completely, but patient is having extremely photophobia. Why? Because the synechia has developed in dilated conditions. So why it happened? Because the patient was prescribed prednisolone 4 times a day and atropine 3 times a day. So inflammation was getting controlled very slowly, whereas the atropine, which is a long-term actually cycloplegic, the eyeball pupil was dilated for a longer time. So the patient developed synechia in dilated conditions, and now the patient is having a lot of photophobia. So that actually you should. So in these conditions, if the inflammation is severe or you are using atropine, remember you should use prednisolone at least 10 times a day. So 10 times a day, and then only you can justify the use of atropine, because then only you can control the inflammation. The second thing is, don't inject anything if you are not sure. This is a patient one of my referral doctor has sent. So he saw this kind of lesion and just injected the intravitreal steroid and see how it became. So it was a small subretinal abscess, it became endogenous endophthalmitis. So don't inject if you are not sure what you are dealing with. Absolutely no to local steroid. So always you remember local steroids, like you can give triamcinolone, like injection, PST injection or intravitreal injection. These are very good when you are dealing with unilateral non-infective uveitis, inflammatory macular edema, and special circumstances like a pregnant lady or lactating mother with uveitis. How you'll treat? You can't give oral steroid or any drug which will be hazardous for the child. So you can actually use local steroid in these conditions, but don't use the local steroid or intravitreal or periocular steroid if it is a part of a systemic disease. And if the patient is having steroid responder and you are not sure about infection or inflammation. And severe vitreitis, you can't see anything inside the fundus, don't give any injection because you don't know what is there beyond the vitreitis. So this is, I always tell that there is a Chinese proverb. So the Chinese proverb says that the unlucky doctor treats the head of a disease, the lucky doctor treats its tail. So to be successful in your clinic, you should treat the patient from head to tail. So I'll give you an example. If you are treating only the anterior uveitis without checking any other ocular manifestations are there or not, and not looking into the systemic manifestation, what will happen? This is the case. You are seeing a case of Vogt-Wanagi-Harada disease. You are only giving topical steroid for the granulomatous uveitis. You are not realizing that patient is having vitreitis or exudative retinal detachment. You are not realizing the patient is also having vitiligo, tinnitus and meningitis, and you are ignoring the signs. Definitely the patient will go to some other doctor who will evaluate and treat the patient successfully. So drug history nowadays, any uveitis come, you don't know the name, at least Google the name, it will tell you which drug the patient is taking. So remember this drug, you can take the photograph also. These are the drugs are notorious to cause actually uveitis in patients, especially this biphosphonate. These are the patient, these are the drug rheumatologists or the orthopedician they're giving for the perimenopausal women or any patients with. So this typically presents with severe anterior uveitis or scleritis like picture. Again, in children, this thing that we remember, these children are this thing you need to rule out few. So I always give this mnemonic child. What is this? Complications are often presenting sign. If you see band-shaped keratopathy, squinting, tilting head, always evaluate under general anesthesia. Hunt for the inflammation. We are like often these patients are treated with an allergic eye disease like loteprednol and all this will be treated. And here the steroid is not the treatment. Only they need immunosuppressive. Methotrexate is the drug of choice. Lens, if you give topical steroid, they will develop cataract, and sometimes you can't place intraocular lens in these children. And drops should be used very carefully. So this is all about showing this is that child, which Dicky referred me, that Behçet disease patient. So don't wait long only giving steroid. Few patients you need to actually send to a higher center for so that they can be started on biologic and other things. So because there is a saying, Hippocrates says that prima non necessary, means first don't do harm. So there is little wisdom in waiting for irreversible damage to happen and then go for hunting. So because always guide the patient properly for that. That brings me to 1 minute. So I'll just conclude with this how we should actually treat a case of uveitis. First, take a proper history. Comprehensive eye examination, examine the patients, how the patient having anterior chamber, posterior segments are there, and then do a systemic evaluation, then you do the laboratory investigation and then go for the treatment. So if you see this is a case, my last case here, a case of hypopion uveitis. Now this hypopion uveitis can present in different form to your clinic. First, this patient can come to you with anterior uveitis, severe fibrinous reaction, history of lower backache and recurrent attacks. What will be your diagnosis? Yes. So now what test you will do? You don't need to do other tests. You will only do for this hypopion case, you will do HLA-B27 and X-ray of sacroiliac joint. That will actually clinch. Now this patient's now having panuveitis, mobile hypopion and giving history of recurrent and oral genital ulcer. So these are the cases you don't have to do HLA-B27 and all. You will do HLA-B51 and send the patient to a rheumatologist because it's a case of Behçet disease and presenting with a hypopion. Now the same patient, same kind of picture, a patient is coming with you can see severe inflammation in the vitreous, You can't see vitreous. It's so much vitreitis is there. There is patient is giving history that he was admitted in civil hospital for 1 month back. Lot of venous fluids were given. High diabetic and telling you he has a carbuncle in the thigh also. So now in this patient, what is your diagnosis? You know that it's a case of endogenous endophthalmitis. So you need to do a vitreous biopsy and send the patient for blood culture and urine culture so that you can identify the organism. If possible, the vitreous biopsy also should send and give intravitreal injections for that. So that's all for today. Thank you.